Thank you for joining us today for our webinar, Breast Health, Understanding Your Breast Cancer Risk. Hi, my name is Emily Kohik, and I'm a nurse practitioner at Redeemer Health and the moderator for today's program. Before we begin, there are some housekeeping notes and instructions for the program. I'd like to start with a disclaimer for today's program. The information presented today is not intended to diagnose, provide treatment options, or replace the advice and care of your healthcare team. Please seek out medical advice and care from your healthcare team as it pertains to your individual situation, and do not delay care. We have some additional information about today's program. This program is being recorded. All attendees are muted for the duration of the program and will not appear on video. The Q&A session will be held at the end, and you can submit your questions utilizing the Q&A session feature at the bottom of your screen. Please do not submit any questions pertaining to personal health information. Here are the topics we'll be covering in today's webinar: the incidence of breast cancer, the breast cancer paradigm, risk factors, risk prevention and stratification, and future direction. It is my great pleasure to introduce our presenter today. Dr. Malini Iyer is a breast surgeon with Redeemer Health in partnership with MD Anderson Cancer Center at Cooper. Dr. Iyer is an accomplished surgeon who specializes in breast oncology and breast surgery. She has dedicated her career to her management of diseases of the breast with a special focus on the treatment of breast cancer. Dr. Iyer, welcome.
Thank you, Emily. It is my great pleasure to talk to you all this evening. October is Breast Cancer Month, and what better time to discuss this disease, its incidence in the world, as well as ways in which we can identify risk and possibly prevent breast cancer. Breast cancer is one of the commonest cancers in the world among women. In fact, it is the most common cancer in women worldwide, with the incidence being highest in the developed world. As you can see in this graph from the World Health Organization, highest incidence of breast cancer exists in the North Americas, in Europe, and in Australia. In the United States, breast cancer accounts for 14 to 15% of all cancers. It is the commonest cancer among women, and unfortunately, the second highest cause of mortality or cancer mortality in the United States. Among all women in the United States, the highest incidence occurs in non-Hispanic, white, Caucasian women. If you notice in this slide, incidence is about 130 per 100,000 women. Incidence is a little lower in African American women, and a little lower than that in patients of Hispanic descent, Asian women, Asian Pacific Islanders, as well as Alaskan women and Native American women. If you look at the slide on the side, you can actually see the incidence of cancer in these various ethnicities over the course of the last decade. And cancer risk and incidence has decreased initially and then sort of leveled off over the last decade or so. So breast cancer is a disease that occurs mostly within the ductal elements of the breast. If you look at this breast cancer paradigm that I have illustrated here, what you see on the left is a single duct of the breast with a nice single layer of cells lining it, and that's a normal breast duct. As we proceed through our reproductive years, the breast gets stimulated on a monthly basis and then involutes at the end of every menstrual cycle. So it is common to find the breast ducts containing more cells per surface area, and this condition is called hyperplasia and is a normal fact of breast growth and development. With time, however, the breast gets stimulated by estrogenic stimuli, and then some atypical or abnormal cells can develop within the duct, and this condition is depicted in the second little circle that you see and is called atypical ductal hyperplasia, or proliferative atypical changes in the breast. This entity is considered a precancerous or a pre-invasive cancerous state. And we identify women in this state as being at high risk. As we proceed with further stimulation of the breast, anywhere from 10 to 15 years down the road, a small cancer can develop in such ducts. And this cancer is called an in situ cancer or ductal carcinoma in situ. This is a pre-invasive cancer. It does not spread. It's contained within the walls of the duct, and incidence is significant. However, there is very little mortality associated with this kind of cancer. and survival is over 99% lifetime. Finally, cancer does then tend to break out of the duct and then has the propensity to spread via channels called lymphatics or through the bloodstream to various parts of the body, and when it is considered to be stage 4 cancer or cancer that has spread elsewhere to distant organs. So this is the breast cancer paradigm. Till recently, we were very focused on management of breast cancer, as well as local regional therapy and systemic therapy of breast cancer. In the past 2 decades, it's become increasingly important to identify patients at risk for cancer at the very early stage of this paradigm, and possibly even prevent cancer at a stage when you are having hyperplasia or atypia within the ducts. So my talk today is going to pertain to identifying risk factors for breast cancer and possibly preventing breast cancer. This is important because even though incidence and mortality from breast cancer has been decreasing, it accounts for a significant amount of mortality in the United States. It is estimated that in the year 2021, over 240,000 cases of breast cancer will be identified, and more than 40,000 women will die of this disease. And hence, this becomes even more important to all of us as women. Now, the main factor is, who is at risk for breast cancer? Unfortunately, it's a sobering thought to realize that all women are at risk because we have breasts, and breast cancer occurs almost exclusively in the female breast. It is important, however, to recognize that 1% of all breast cancers can occur in men. These are usually cancers that occur in families with a genetic predisposition to cancer. So men aren't exempt from this disease and should be evaluated and treated if they have breast masses or family history of significant risk. Now, all women have about a 1 in 8 lifetime risk of cancer, and this equates to about a 10 to 11% risk on an average. If you look at the slide on the right, you notice that the rate of incidence of breast cancer is quite low below the age of 40, and after 40, the risk rises steadily every decade till about our 80s, after which risk of breast cancer falls off. This is why we start screening mammography around age 40. What is important to realize is that 13% of all breast cancers do occur in women below the age of 40, where we usually do not start screening. Hence, it is important for all women to realize that they should do breast self-exams, possibly see their primary care physician or gynecologist every 2 or 3 years before this age, so that they can be evaluated for the possibility of a breast lump or issues with the breast. Risk, therefore, increases with age, as we notice. Race and ethnicity also impact incidence of breast cancer, as I documented in the slide before. If you notice, incidence of breast cancer is a little lower in African Americans. However, the mortality indicated in the bright blue is much higher. Now, this is related to various factors, including the fact that some African American women have breast cancer at younger ages. They sometimes tend to have the more aggressive forms of breast cancer. The other issue is socioeconomic factors, access to healthcare, and other healthcare factors. So it does become important to afford everybody access to adequate healthcare and screening of all ethnicities. Now, what are the risk factors other than age and being a woman? These are factors that we cannot modify, but there are some factors that we might be able to modify. So I've listed various factors here. Reproductive factors, which actually govern the amount of estrogenic stimulation that our breast gets over the course of a lifetime. Exogenous hormones, this includes oral contraceptive therapy and hormone replacement therapy. Genetic factors and familial factors, which I will touch upon. The incidence of changes in the breast and benign breast disease, as we call it, or fibrocystic changes in the breast. Lifestyle and dietary factors can also affect risk for breast cancer, including other environmental factors, including radiation exposure. There are some miscellaneous factors that I'll touch upon briefly at the end of my talk. So let's get going on all these factors. One of the things that affects risk for breast cancer is our exposure to various female hormones over the course of our lifetime. The main hormone that we are concerned about is exposure to the female hormone estrogen. So in this regard, the various factors that can affect breast cancer risk are listed here. Menarche or onset of menstrual cycles is a factor that affects breast cancer incidence. Early menarche is defined as before the age of 11. Every 2-year delay in onset of menarche decreases breast cancer risk by about 10%. So the later the menarche of a young lady, the lower her incidence of breast cancer. Pregnancy and age at first pregnancy also affects incidence of breast cancer. We define early pregnancy as below the age of 35, and patients who are below the age of 20 and pregnant have almost a 50% reduction in risk of breast cancer as compared to patients who have children after the age of 30. Having children beyond the age of 35 is considered late parity. A pregnancy and age at first pregnancy also affect incidence of breast cancer. Early pregnancy is defined as anything before the age of 35. If a person becomes pregnant below the age of 20, their incidence of breast cancer is less than 50% that of patients who have late pregnancies, and late pregnancies is defined as a pregnancy after the age of 35. Pregnancy between 30 and 35 also carries lesser risk than having pregnancy beyond the age of 35, and not being pregnant at all increases risk of breast cancer. It is unusual that if you have a late pregnancy beyond the age of 35, your risk is higher than a woman who may not have had a child at all or is nulliparous. The exact reason for this is not known. The number of pregnancies also decreases your risk. Each pregnancy sort of decreases the risk of breast cancer by about 7%. And hence, if a woman has multiple children, her risk of breast cancer is going to decrease significantly. Spacing of births may affect incidence of breast cancer, but this is not very significant, so I'm not going to dwell on it. Lactation and breastfeeding also decreases incidence of breast cancer. If a person breastfeeds for 12 months or so, their risk of breast cancer is decreased by about 4 to 7%. This is a little tough in this day and age with a lot of women working. However, this is one of the modifiable risk factors for breast cancer and is considered good for both the mother and the child. And I would encourage it in all women if they can do it and circumstances do allow them to do it. Age of menopause also affects breast cancer risk, with late menopause being defined as menopause after the age of 55. What this means is that during our reproductive years, we are exposed to estrogen for a longer period of time, and hence the breast also is able to differentiate or de-differentiate by these hormonal influences. All these issues are endogenous hormonal issues. Now, exogenous hormones in the form of oral contraceptives and hormone replacement therapy can also affect risk of breast cancer. In this slide, I've depicted the risk of oral contraceptive therapy on breast cancer risk. If you look on the side, if a patient has taken oral contraceptives for about 10 years, her risk of breast cancer increases by about 25%. So if a person's risk is 1% at any particular age, their risk will increase to 1.25. This is called relative risk of breast cancer. Hence, oral contraceptives, relative risk of producing breast cancer in a young woman who takes oral contraceptives for up to 10 years is about 25% or 1.25. Duration of usage of oral contraceptives and younger age at starting these medications increases your risk. Low dose contraception also increases risk, though it is mild. And after you stop taking oral contraceptives, risk drops off almost immediately. And by about 10 years, the risk is the average population risk. Hence, even though oral contraceptives do increase risk of breast cancer, in clinical practice, this does not land up being very significant. Most women take oral contraceptives in their second and third decade. Then, if they wanted to start having children, they do. And subsequently, by the time breast cancer risk is increasing at age 40, they're at least about 10 years from using oral contraceptives and at average population risk. So in general, we do not discourage oral contraceptive usage among young women. However, a benefit of oral contraceptives is also that it decreases ovarian cancer risk by about 50%, as indicated in the slide by the purplish dark blue line. It also decreases the risk of endometrial cancer, and so oral contraceptives do decrease the incidence of ovarian cancer by about 50%, and also decrease the incidence of endometrial cancer. Hence, usage of oral contraceptives should always be looked at from a risk-benefit standpoint, and we do not discourage usage in young women. Now, hormone replacement therapy is something that many postmenopausal women use. In the 1990s, hormone usage was about 40% in the United States. Around that time, a big study was performed called the Women's Health Initiative Study. What this was looking at really was the health benefits of hormone replacement therapy on postmenopausal women, especially as it related to cardiovascular risk. So the first Women's Health Initiative study looked at a combination of estrogen and progesterone, which is called PremPro. PremPro was given to women in two cohorts. One set of women received hormone replacement therapy while the other didn't, and they were followed over a course of 5 to 10 years for incidence of cardiovascular issues, stroke, and other problems, as well as breast cancer risk. In about the fourth or the fifth year of the study, it was noted that breast cancer risk was significantly higher in the group of women that used hormone replacement therapy and the combination hormone replacement therapy with estrogen and progesterone. When this was done, the study was actually discontinued and unblinded, and the study was then followed up for a further period of time. In a nutshell, breast cancer risk and incidence was increased in patients with hormone replacement therapy, but the order of increase was in about 8 to 9 cases per 1,000 women. This equates to about a 0.9 to a 1% risk of after 5 years of hormone replacement therapy. Now, this risk does persist a little longer. Hence, if you took hormone replacements for about 10 years, your risk is possibly a little higher. Longer-term follow-up and other meta-analysis of such data have, however, indicated that the risk is somewhere between 4 to 9 extra cases per 1,000 women with 5 to 10 years of usage of hormone replacement therapy. Now, the second Women's Health Initiative study looked at estrogen alone, which was in the form of a drug called Premarin. They found that estrogen alone did not significantly increase the risk of breast cancer, though some other studies in the world have indicated a mild increased risk. Hence, it is important to realize that combination therapy is what leads to a higher risk of breast cancer. Cardiovascular risk, however, was not significantly altered, and hence a person should never use hormone replacement therapy specifically for reducing their cardiovascular risk and increasing their heart health. Hormone replacement therapy does improve bone health and can be used in that circumstances and for all menopausal symptoms. And once again, we do not discourage women from using hormone replacement therapy if they needed it. If a person is considered at higher risk, they should realize that using such medications increases their risk by about a 1% or 2% more than whatever baseline risk they have. Now, the next factor that affects breast cancer risk is familial history. Looking at this chart on the side, I do want to stress that sporadic breast cancer occurs in 70% of our patients. That means 70% of breast cancer occurs in women with no family history at all. About 15 to 20% of breast cancers are in women with some family history, and about 5 to 10% are in women with a significant family history and something called a genetic predisposition to cancer. In identifying these women with genetic predisposition, we look for incidence of young breast cancer in the family, and we define young as below the age of 45. If there are more than 2 members in the first, second, or third degree from a patient, we look for young breast cancer in 1 member below the age of 50. Certain types of aggressive breast cancer, called triple negative breast cancer, in any member in the family less than the age of 60, also increases incidence of having genetic predispositions. And if there have been multiple breast cancers in a particular patient, ovarian cancer in first, second, and third degree relatives, and also pancreatic and prostatic cancer within the family, we worry about a possible genetic predisposition. One of the other things that leads to high risk of genetic predisposition is having male breast cancer within the family. And the pancreatic and prostatic cancer can also be within male members in the family. So we look for all this when we look at cancer pedigree in the family history that we take when we see young patients or older patients presenting with either breast symptoms or concerned about their risk for breast cancer. Now, with regards to genetic predisposition, these patients are considered at a prohibitively high risk of breast cancer. The average risk, as I showed you initially, was about 1 in 8 lifetime risk. That really means that by the time we reach the age of 80, our risk is about 1 in 8. That risk is not there when you're at the age of 40 or so. However, that equates to about a 10 to 12% lifetime risk. Now, in patients with a genetic mutation or a genetic predisposition, and I've circled some here on this chart, especially something called the BRCA mutation 1 and the BRCA2 mutation. Patients with such mutations have up to an 80 to 85% risk of breast cancer in their lifetime, and this is prohibitively high. The BRCA1 and 2 genes are part of a syndrome called the hereditary breast and ovarian cancer syndrome. And in such patients, ovarian cancer risk is also in the order of about 40 to 60%, which is again extremely high. Other cancers can also be associated with these, and a few are listed here, and these include pancreatic cancer, prostatic cancer in men, and melanoma in men or women. The other genes listed on the slide are also significantly associated with risk, and this risk is in the order of 50% or more. So these risk mutations are considered high-risk mutations and have something called a high penetrance. That means from generation to generation, they do get inherited and do exhibit breast cancer much more than cancer genes that have something called a low penetrance. There are multiple other genes that can lead to breast cancer risk, and some are listed here in this slide. These are considered moderate risk genes or low penetrance genes, and their risk is something in the order of 2 to 4-fold of the average risk. That would be about a 20 to 40% risk. And so nowadays, in patients who have various family histories of breast cancer, the other factors that I indicated earlier, we do offer genetic testing, and we try to identify all these genes. We do try to identify other genes that could affect other cancers too in something called panel testing, and we consider these patients significantly high risk. Now, other things that affect risk are what we call proliferative breast changes. I did indicate that estrogen over the course of a lifetime stimulates the breast cells and ducts to produce more ducts and more cells, and sometimes changes can occur within these cells and lead to atypical cells and subsequently possibly cancer developing within the duct or the lobular tissues of the breast and then becoming an invasive cancer. And this stimulation with every menstrual cycle leads to what we call fibrocystic changes. Fibrocystic changes are actually benign changes and referred to as benign breast disease. However, when we have a lot of proliferation of cells within the ducts of the breast and the tissues of the breast, we call it proliferative fibrocystic changes, and this can lead to a higher incidence of breast cancer. However, for benign, non-atypical changes, this increased risk is quite small, and doesn't really affect patients. Having multiple breast biopsies, however, is a sort of a surrogate for increased proliferation within the breast tissue and can increase risk. When a patient has a benign breast biopsy, but atypical cells are found in this entity called atypical ductal hyperplasia, there is an increased risk significantly to about 15 to 20% at least. And when there is family history in addition to atypia, risk is significantly increased. This order of risk for an average patient with atypia or another entity called LCIS, lobular carcinoma in situ, is in the order of about 20 to 25%. That is double the average population risk. And such patients are identified as being high risk for breast cancer and offered increased surveillance and other methods by which they could decrease their overall risk for breast cancer and possibly prevent the disease. Now I'm going to touch upon various modifiable factors that could affect risk for breast cancer, and among these are what we call lifestyle factors. Alcohol has been found to be a significant risk for breast cancer. 3 to 4 servings a day of alcohol, and a serving is defined as something between 20 and 30 milliliters of alcohol a day, can increase breast cancer risk over a course of a lifetime of about 34%. Alcohol definitely increases breast cancer risk among premenopausal women. Starting alcohol drinking early in life or later in life, and binge drinking also affects the risk significantly. And the risk seems to be linear and is affected by the amount of alcohol taken in. Type of alcohol seems to matter a little bit. For some reason, breast cancer risk is higher with intake of spirits, a little lower with intake of wine, and the least with intake of beer. Why exactly, I'm not sure. However, the amount of alcohol does make a difference. This is something that all of us can modify if we want to decrease or modify our risk of breast cancer. The next important factor is smoking, and smoking has been conclusively proven to increase the risk of various cancers. As far as breast cancer is concerned, starting smoking early in life in your teens and higher prolonged usage of smoking can increase risk. However, in large studies and what we call meta-analysis of all the data, when we correct for other factors such as alcohol intake and other lifestyle factors, smoking in itself does not land up being an independent risk factor for breast cancer. Hence, when you look at the overall data, smoking does not increase risk of breast cancer. However, as oncologists and doctors, we do encourage that most patients try cessation of smoking, as this decreases risk of cancer and various other diseases, including cardiovascular disease. Physical activity is another important factor that can alter our overall risk. Moderate activity over the course of a lifetime reduces breast cancer risk by about 10 to 12%. Moderate activity is defined as low impact aerobics. You can include walking in this activity. Walking about 45 minutes to 1 hour, 3 to 5 times a day would be included in moderate activity and lowers your risk for cancer. Higher intensity activity includes high intensity interval training, jogging, or running, and these activities increase risk by a slightly increased factor. So this is another modifiable thing that we can do to lower our overall risk. Dietary factors may also impact our incidence of breast cancer. The thing that has been studied significantly is soy intake. There have been various studies looking at intake of fruits and vegetables, various foods of different glycemic content, carbohydrate intake, fat intake, as well as various antioxidants. The problem with such studies is that it is extremely difficult to standardize these nutritional elements and also standardize behavior over long periods of time. Hence, there is no clear data that links one food group to either an increase or decrease incidence of breast cancer. Soy intake has been studied, and a high intake of soy protein is protected in some ethnicities, especially in Asian populations. However, in Western Caucasian populations, a high soy intake has been associated with a slightly higher incidence of breast cancer. Once again, it is very difficult to standardize such soy intake, and hence we do allow or recommend that patients take a moderate amount of soy if they wanted to, and not worry too much about breast cancer risk. The reason soy might impact breast cancer risk is because of something called plant estrogens or isoflavones that soy contains. And this would lead to increased estrogenic stimulation of the breast and possibly alter incidence of breast cancer. Other elements that have been studied include various antioxidants and vitamins. Among these, vitamin D has been studied, and there is some indication that a low vitamin D level might increase a person's risk for breast cancer. Incidence of decreased vitamin D levels is quite high in the United States, and there are things that we can do to modify this problem. Exposure to sunlight, and that would be about 15 minutes of exposure about 3 to 4 times a week, is actually adequate to maintain a good vitamin D level and produce vitamin D in our skin and other organs. Vitamin D3 is considered better than something called vitamin D2, and intake of about 600 units of vitamin D per day should be adequate for the average patient to maintain adequate vitamin D levels and alter possibly your incidence of breast cancer. Other vitamins have been studied. There has been some indications that intake of folic acid or folate might alter incidence of breast cancer. However, this has been really found to be in patients with high alcohol intake, where if one takes folate and folic acid and has a moderate amount of alcohol intake, one might be able to protect against the increase in breast cancer risk slightly. Hence, taking a good multivitamin, possibly increasing our vitamin D intake and calcium intake in our postmenopausal years might lower our risk of breast cancer slightly. Fat intake has also been studied, and there are some studies that might indicate that increased incidence of breast cancer occurs in patients who have an increased fat intake. However, this equates more to overall health, weight, and BMI rather than fat intake per se. This comes to my next big point. Obesity and weight has definitely now been proven in multiple studies to be associated with increased overall cancer risk of various kinds, including breast cancer. Now, we define obesity by something called the body mass index, or the BMI. BMI is your weight in kilograms divided by the square of your height in meters. A body mass index of a number 25 or less is considered a normal body mass index. If one is overweight, our body mass index is somewhere between 25 and 30. If we are above 30 BMI, we are considered obese. Patients who have BMIs above 35 are significantly obese, and patients who have BMIs above 40 are considered morbidly obese. There has been an explosion of data and research nowadays into the link between obesity and breast cancer. Obesity leads to increase in fat cells numbers as well as size within the body, and this is associated with an overall increased inflammatory state within the body. Fat cells and obesity can also increase various hormonal factors, various growth factors, and various chemicals called cytokines within the body that lead to growth of cells and multiplying of cells and proliferation. Within the breast, this can lead to more proliferative changes. And as we spoke before, proliferative changes can lead to higher incidence of breast cancer. Obesity has been definitely linked with increase in breast cancer risk. This is seen most starkly in postmenopausal women. Every 5 kilogram per meter squared increase in our weight and BMI increases breast cancer risk by 12%. In fact, breast cancers that are hormone driven, or what we call estrogen receptor positive cancers, there is an increase of about 80% in such cancers in postmenopausal women who are obese. The reason for this is that in our postmenopausal years, estrogen is mainly produced in our fat cells. When we are premenopausal, estrogen is produced in the ovary, but in the postmenopausal state, precursors of estrogen circulate in the body, and within the fat cells, there is an enzyme called aromatase that converts this inactive estrogen into the active form of estrogen. Hence, when we are heavier, we have a relative estrogen excess in our body, and this is what equates to an increased breast cancer risk. It has been clearly shown that there are poorer outcomes in breast cancer with obesity, and there is also a higher incidence of breast cancer risk in such patients. Funnily, in premenopausal women, obesity actually decreases our risk by about 50%. This is because the estrogen produced in the ovary possibly suppresses estrogen production elsewhere, and obesity in such patients is linked to a decreased incidence. This does not mean that we would recommend a patient be heavier in their premenopausal years. Being heavy increases risk of various other diseases, and we still would recommend that a patient try their hardest to maintain a good BMI over the course of a lifetime with lifestyle modification. The other major factor that could increase risk of breast cancer is ionizing radiation. Now, ionizing radiation from such major world events like the nuclear bomb exposure has been very clearly documented. In breast cancer risk per se, ionizing radiation as given to treat patients with various other cancers is what increases risk of breast cancer. So it has been proven that if a patient has received mantle radiation in their younger years for something called Hodgkin's lymphoma to their chest and chest wall, their risk of breast cancer is very significantly increased. If patients are below the age of 20 when they received this chest wall radiation, their risk is very significant. Somehow, the risk does not persist beyond the age of 40. The risk increases in the third decade of life, and it is a lifetime risk once a patient has been exposed in their younger years, and such patients are considered significantly high risk for cancer and should be screened for cancer with increased screening. We recommend that patients with ionizing radiation exposure in their younger years should start having MRIs of both breasts after the age of 40 to try and detect cancer at an early stage if it were to occur. The other question is, what does radiation exposure from mammography do to breast cancer risk? An average mammogram exposes a patient to about 3 to 5 units of radiation. An average 3D mammogram is about 2 to 3 units of radiation higher than a regular 2D mammogram. Over the course of a lifetime, there has been no study that has shown that such level of ionizing radiation increases risk of breast cancer. In this context, a single CAT scan exposes a patient to about 56 to 60 units of radiation, and one needs about 6 to 7 CAT scan exposures to come to the level of possible ionizing radiation and increased cancer risk. Hence, we still do recommend that mammography start at age 40 and be performed every year, though there are studies that recommend every 2 years should be adequate in certain subgroups. Now, breast density is another factor that has come very much in the limelight over the past 2 decades. Breast density is sort of a surrogate for active breast tissue and proliferative changes in the breast and active ductal elements in the breast. And as we spoke, it is these ductal elements and proliferative changes in the breast that can lead to breast cancer. Hence, having extremely dense breasts can increase the risk of breast cancer by anywhere from 1 to 3.5 fold for the average patient. If you look at the slide, it shows the 4 stages of breast density. We call them BIRADS 1, 2, 3, and 4. The slide on the left shows an extremely fatty breast with very little active ductal elements. And on the right, you can see a breast that is extremely dense with a lot of white tissue. And this is a grade 4 density. The patient on the grade 4 density scale has a 3 to 4-fold increased risk of breast cancer compared to the patient who has a fatty breast or is 1 on this particular scale. Hence, it becomes important for patients to know their breast density and undergo appropriate screening so that cancer can be detected. With regards to this, we do recommend that 3D mammography is the best screening for high-density breasts. We also do recommend that patients consider what is called breast screening ultrasound or automated breast ultrasound. An average automated breast ultrasound increases detection of breast cancer by 4 to 5 extra cases per 1,000 women screened. In patients with significant breast density and possible high risk for breast cancer, we would add MRI screening to the mix so that we are able to detect cancers within this very dense breast tissue. So now that we have spoken about various risk factors, is there anything we can really do about this? If you look at the slide, you will obviously agree with me that there are non-modifiable risk factors. These include aging, us being women, and our family history. Reproductive factors to a large fact cannot be changed. However, having children is a modifiable risk factor. Having children earlier in life is something that we can change, and possibly having more children and parity is something that we can modify. So it would be ideal if we could all have our children below the age of 35, but in this day and age, it is tough with more educated women and women in very high pressure jobs where they do delay having a family. But if there were high risk within the family, it would be nice if a person could choose to have their children earlier if all other circumstances fit. The other thing that we can modify among this is our intake of estrogen. And as I told you, we can avoid oral contraceptive usage and hormone replacement therapy if possible. However, if a person has significant symptoms in our postmenopausal years and we need to use hormones, it is acceptable to use it as long as we recognize that there is a minimal increased risk, a 1 to 2% possible increased risk over our lifetime. And again, I told you that in younger patients, oral contraceptives in clinical settings do not really seem to modify risk at the age at which breast cancer risk starts increasing. Risk assessment is something that we do offer to most women who have concern about breast cancer. We try to define women as being at average risk for breast cancer, at maybe moderately increased risk, and high risk for breast cancer. The way we do this is by various things called risk assessment models. 2 models and common models are listed here. These are the Gale model and the Tyrer-Cuzick model, and they take into account all the risk factors that we've spoken about. Gynecological factors, age of menarche onset, age of menopause, parity, number of children, whether patients have had breast biopsies or not, and whether atypical cells have been found. And we also assess family history, either in first, second, or third degree relatives of the patient. Using these various factors, we calculate a number and attribute that number risk to the patient. Patients are considered at high risk for breast cancer if their 5-year risk is more than 1.7% and their lifetime risk is higher than 20 to 25%. These were the numbers used in the initial trial, the P1 trial, that looked at breast cancer prevention with a drug called tamoxifen. In patients at average and moderate risk, that is less than 20% lifetime risk, we recommend that they start and be diligent about breast screening mammograms. These usually start at age 40, though there are other studies that recommend otherwise. And we do, in patients with dense breast, recommend that they try supplementing screening with automated breast ultrasounds on an annual basis. And this does increase our detection of breast cancer in certain patients. Now, lifestyle modification is the first thing that we can change. Among these, as we spoke, alcohol consumption can definitely be modified, and we do recommend less alcohol intake. If one has 3 to 4 drinks in a whole week, and one serving of a drink is about 20 to 30 milliliters of alcohol, that would be considered acceptable. And if we have no alcohol at all, that would definitely be even better. Physical activity is really important. And they do say that if a person does moderate exercise of about 3 to 5 times a week, breast cancer risk can be modified. Now, in itself, this is by a factor of about 10 to 12%, but it is additive to everything else that we do, including alcohol consumption, healthy diet, and weight management. And hence, I think every little bit counts. A healthy diet does matter. We do say everything in moderation, soy intake in moderation, maintaining vitamin D levels, possibly taking a good multivitamin with B vitamins and folic acid, and decreasing and maintaining a moderate intake of fats. And all this leads into the main issue, which is trying to maintain a healthy body weight and a healthy body mass index, or BMI. Now, multiple studies have been done looking at health in women and hormonal factors that might affect health. And in these studies, there has been a very, very clear indication that reduction in weight and reduction in BMI reduces risk for breast cancer. In fact, in the WINS study, as indicated here, a 6-pound weight loss decreased risk of breast cancer among the study participants by 20%. And that is extremely significant. It's almost as good as taking a drug to lower your risk of breast cancer over the course of 5 years. And hence, we do recommend that patients try to remain in a healthy BMI range and possibly try about a 10% reduction in their body weight to reduce their risk of cancer. So lifestyle modifications are something we've touched upon. Other things we do recommend in patients of normal risk as well as high risk patients is screening mammograms annually, plus minus automated breast ultrasounds. In patients at high risk, higher than 20% lifetime risk, we do recommend screening MRIs annually. In patients at extremely high risk, these are patients with genetic mutations, we do start screening MRIs even at age 25. But this is because patients' risks are in the order of about 60 to 80% over the course of their lifetime. And MRIs are started on an annual basis at age 25 and then continued along with mammograms from age 30. This is significantly lower than the average population and other patients at high risk, where we start most of these things at age 40. A breast self-exam monthly is indicated. We usually tell patients to examine their breasts after their menstrual cycle is completed. This is somewhere between day 7 and 14 of their menstrual cycle. This is when their breast is least active and most quiescent, and small masses can be detected better. A biannual clinical breast exam, that means twice a year, is indicated in patients at significant high risk, but in patients with average and moderate risk, this can be once a year after the age of 40. Prior to that, a breast examination every 2 to 3 years is acceptable. The next main thing that we can do to prevent cancer is to look at either medications or surgical means to decrease a patient's cancer risk. This becomes important in patients at high risk. So for all patients at high risk, patients with more than 20% lifetime risk, there are medications that can significantly lower breast cancer risk by about 50% or so. This slide indicates the breast cancer prevention trial that was conducted initially. This used a drug called tamoxifen, or a systemic estrogen receptor modulator, to try and see if breast cancer risk could be lowered in patients at higher risk. And the Gale model risk, which I indicated in the earlier slide, was used to define patients at high risk. When you look at these two slides, you can see that the purple line is the patients who did not take tamoxifen, and the pink line is the incidence of breast cancer in patients who took tamoxifen. This study showed that if one took tamoxifen for 5 years, you lowered your risk of both pre-invasive cancer, that's ductal carcinoma in situ, and invasive cancer by an incredible 50%. And hence, we now recommend tamoxifen to all premenopausal and postmenopausal patients who might like to lower their risk significantly. After this initial trial was done, multiple other drugs were studied because tamoxifen had some bad side effects. The good effects of tamoxifen were lowering breast cancer risk across the board by half, or 50%. Tamoxifen also improved the lipid metabolism in the body and lowered the bad low-density lipoprotein or cholesterol. Tamoxifen strengthened bones in many postmenopausal patients, and that was extremely good. However, the side effects of tamoxifen are significant, and there are some serious side effects. These include a 1% risk of uterine cancer in the lining of the uterus, an increased risk of what we call thromboembolic phenomenon, which is blood clots in our veins that can break off and go to the lung, cause something called a pulmonary embolus, and a slight increased incidence of stroke. Because of this, the uptake of tamoxifen usage has been a little slower than you would imagine, and there has been an effort to try and find better drugs or better SERMs. In this regard, a second trial was then conducted called the STAR trial that looked at another drug called raloxifene or Evista for breast cancer risk. Evista had been used many years prior for treating postmenopausal patients with osteoporosis and improved bone density and health in all these women. It was also incidentally found to lower risk of breast cancer and hence was studied head-to-head with tamoxifen in this trial. Proliferative or Evista also causes a 50% reduction in incidence of breast cancer if taken daily for up to 5 years. If you look at this chart, when you read it, you look at the darker lines and the uncovered little circles as the line for raloxifene incidence of breast cancer and tamoxifen's incidence of breast cancer, and they are just the same, meaning that both drugs have the same effect on breast cancer incidence and reduction of breast cancer incidence in patients. On the right side of the slide, however, you see that the darker line and the lighter line diverge. What that shows is that raloxifene, for some reason, does not affect incidence of pre-invasive cancer or DCIS, and hence tamoxifen in that regard is a better drug. However, raloxifene does have lesser side effects than tamoxifen. It has the same effect of breast cancer risk for invasive breast cancer, lowers cholesterol levels, strengthens bones, has a lesser incidence of endometrial cancer and blood clots, but there is no reduction in pre-invasive cancer, and one still gets postmenopausal type symptoms with raloxifene. Now, raloxifene is only indicated in postmenopausal women. Since then, multiple other drugs have also been tried. These include a group of drugs called aromatase inhibitors. If you remember, I explained that in postmenopausal patients, estrogen seemed to be produced in our fat cells with the help of an enzyme called aromatase. And by blocking this enzyme or chemical, we are able to reduce estrogen production and stimulation of the breast. These drugs include the drug anastrozole and the drug called exemestane. Now, the chart on the right is not really from a prevention trial, but just shows you that the side effect profile of tamoxifen and raloxifene is different from these aromatase inhibitors. The main side effect of these newer drugs is decreasing bone health in patients, and increasing musculoskeletal problems in the form of joint and muscle pains, and increasing osteopenia and osteoporosis. However, these newer drugs have lesser problems in terms of vaginal bleeding, problems with endometrial cancer, and stroke and blood clot risk. Hence, we now have multiple drugs that can significantly lower breast cancer risk in patients with high risk. And for every patient, they need to look at the side effect profile and the risk-benefit ratio to consider taking these drugs. Definitely, if your risk is in the order of 20 to 25%, your reduction is half, that's by about 12%. But your side effect profile might be in the order of 5 to 8%, and hence you may not take the drug. However, if your risk is significant at 50%, these drugs are extremely effective and should be considered to reduce risk. The last thing I've listed in this slide is the last way in which we can reduce breast cancer risk. Prophylactic mastectomy, or removing breasts before cancer occurs, is one way in which we can do this. Prophylactic surgery is only indicated in patients at prohibitively high risk. Usually, we define this as patients with a higher risk of getting breast cancer than not getting breast cancer. That would equate to a more than 50% risk of getting breast cancer from either a genetic mutation, significant family history, in addition to other risk factors. In such patients, it is acceptable to recommend that they undergo prophylactic mastectomies to reduce their risk. In patients with genetic mutations, especially the BRCA1 and 2 mutations, breast cancer risk was reduced by over 90%. That is amazing reduction in risk by performing bilateral prophylactic mastectomies, removing both breasts in order to prevent breast cancer. Hence, you can bring a patient from an 80% risk of breast cancer to about 3 to 4% risk in all. And this is very significant and is offered to patients with high-risk genetic predisposition to breast cancer. Another form of risk-reducing surgery in such patients with genetic mutations is to offer bilateral prophylactic salpingo-oophorectomies. That means removal of both ovaries and tubes in order to reduce risk of breast cancer, and such surgery reduces risk by 50%. Equivalent to risk reduction with 5 years of medications like tamoxifen and anastrozole. And hence, in patients with high-risk pedigree and genetic predisposition to breast cancer, we do strongly recommend that they consider oophorectomy, removal of tubes and ovaries after the age of 40, and bilateral prophylactic mastectomies when they are ready, and preferably after they have completed their families and breastfeeding as they might desire. So we definitely have come a long way. I paraphrase from Robert Frost that the road was long, untraveled, and steep, and we have come a long way to reducing incidence of breast cancer. We now can identify high-risk patients. We can screen them better. We can find cancer at an earlier stage and hopefully completely cure it. Our survival from breast cancer overall is over 90% in all comers and all stages. And we have managed to identify high-risk patients in whom we can offer specific medications that reduce risk by 50%, as well as surgeries that decrease risk by over 90%. And this is truly incredible and amazing. However, we do have promises to keep, and a lot of study is now going into better risk stratification and identification, sometimes looking at various things called SNPs, or single nucleotide polymorphisms that might identify high-risk pedigrees, and possibly different kinds of medications that could affect cancer risk. We are looking at the role of statins in reducing risk, role of vitamin D, something called COX-2 inhibitors, various drugs that might affect and decrease risk in various patients. And hence we do definitely have a long way to go and miles to go before we can sleep in this regard. I thank you very much for your attention, and I'll open the floor to questions and answers.
Our first question, Dr. Iyer, comes from a patient. She says she's 85 years old and a 7-year survivor of breast cancer. She does not want to have any more mammograms. What are your thoughts on her skipping them from now on?
I would be in favor of that. The recommendations for mammography are to start at age 40. Possibly some other recommendations do state that you could start later. However, the time of ending mammography is a little bit of a debate. The Society of Breast Surgeons and the Radiology Societies recommend that mammography can be stopped if the expected life of a patient is less than 10 years from any particular date. So if you took a 90-year-old lady and it was unlikely the lady was going to see 100, she could easily stop doing mammography at that age. So if in our families, people live to their early 90s or maybe till about 95 and you were 85, you could stop doing mammography at this time. It takes 4 to 5 years for all those changes from that early breast cell and that atypia to become a cancer. And it takes another 5 to 10 years possibly for that cancer to do anything terrible to you. And hence it's okay to stop mammography at age 85 if you're 7 years out from a breast cancer.
Okay, thank you. Our next question, does having a history of microcalcifications put you at a higher risk of breast cancer in the future?
So microcalcifications per se do not increase your risk of breast cancer. It's a natural event in the breast that when some cells die by something called apoptosis, some bits of calcium are deposited either in the stroma of the breast or the duct, and that doesn't mean you are going to develop a cancer. However, 20% of a microcalcification could be cancerous, and hence that's something we have to know, that if there are clusters of calcification, you might have a cancer at that time. But if you've had a biopsy that shows benign breast disease within those calcifications, it doesn't really turn into cancer, increases your risk a minimal amount as any proliferative benign disease will. It's not the calcification that's doing it. It's really the process behind the calcification that increases your risk minimally.
Perfect. Thank you again, Dr. Iyer. At this time, we're getting kind of close on our time, so I'm going to wrap it up with one last question for you. I'm going to merge two of our questions together. What is the risk of developing breast cancer as a stage 4 colon cancer survivor? And what are some pros and cons for those considering genetic testing to determine the possibility of developing cancer?
So colon cancer in itself, sporadic colon cancer, is not really related to breast cancer in the sense that if you got colon cancer, you are at no higher risk of developing breast cancer than the average population. However, if your colon cancer was related to any type of genetic mutation or a particular familial kind of colon cancer, then these syndromes do include breast cancer as part of the different cancer things that could happen. And hence, in that situation, your risk of breast cancer could be significant. And that is easily determined by a good colorectal surgeon or a gastroenterologist. They look at the tumor and look for something called microsatellite instability in the tumor. And they also look at your family history to determine if you might be carrying a gene for a colon cancer that may also be coding for a breast cancer. So genetic testing is really, really useful. And from a medical standpoint, we would love if all women who had breast cancer or family history were tested. Basically, because we've only, scratched the tip of the iceberg with this. And there are many people wandering around with mutations for whom we can really do significant things to lower their risk. However, there are some pros and cons to genetic testing. One thing everybody should know is they cannot be denied medical insurance if they undergo genetic testing and are found to be positive. There is a law called the GINA Act that prohibits this. However, if you were looking to have something called life insurance or disability insurance, your premiums might go up if you're found to be positive for a gene, and maybe you will be denied insurance in that way. So from that perspective, sometimes one could delay genetic testing till you've got all your policies in order, and that would be good. The other con for it is it definitely confers a level of anxiety and uncertainty for the patient. And that is something that some people cannot handle or prefer not to handle. And hence, we usually tell patients that if you are undergoing genetic testing, we should have some assurance that you will at least follow recommendations to treat and even follow the necessary screening for it, and you will be able to handle the diagnosis of a positive gene. So we go through an extensive counseling session with most people, talking about what the advantage of testing is, which is really reducing risk if you're positive significantly, and versus these other little social and other familial things that could matter. And then we make the decision. Now, as far as genetic testing, we usually recommend that it be done when the person is of an age where they can appreciate what that means, which means we often say after the age of 18, children can be tested, and preferably in their early 20s. We start screening for cancers at age 25. So we like that if people might be at risk, they should be tested before 25.
Wonderful. Thank you again. At this time, we're going to wrap up because we're running out of time for tonight. Thank you again for joining our webinar, and a special thank you to Dr. Iyer with Redeemer Health in partnership with MD Anderson Cancer Center at Cooper. We hope you enjoyed the program, and we hope we were able to answer some of your questions. For more information regarding our breast cancer program, you can visit our website. It's redeemerhealth.org/breast-cancer. Have a wonderful evening, and please be safe.